Okay. So, good evening, everybody. I'm Dr. Shuichiro Shina, the president of APASL. It's my pleasure to welcome you to the session 11 of the ALCAP program. Today's session deals with radiation therapy for hepatocellular carcinoma. We hope that you will find the discussion and share the both informative and valuable for your clinical practice. And I wish you a fruitful and enjoyable session. And before that, I would like to talk a little about our APASL 2024 Kyoto, which will be held March 27th to 31st at the end of this month. We are delighted to announce you that the APASL 2024 Kyoto has gained 2,314 abstract submissions from 63 countries, all-time high among the 33 APASL annual meetings. And we expect 6,000 participants in Kyoto. And we firmly believe that APASL 2024 Kyoto will contribute significantly to the development of hepatology. And we look forward to welcoming you to Kyoto amid the cherry blossoms in full bloom. Thank you very much. Oh. Can you hear me?
Yeah, you are audible. Professor Sarin also joined now. So, Professor Sarin, we are waiting for you.
So,
Sir, sir, unmute yourself. You are not audible, sir. You are mute.
Thank you, Professor Sheena, and all the members of the ALCAP program. My apologies, I could not join due to my technical limitation. Welcome to all. This is a very popular series now in liver cancer and hepatobiliary cancers. We are very lucky today to have very distinguished moderators and of course very good speakers who are taking the grand rounds. The whole idea behind this series is to have people who are as good as us or the experts, and we should be able to My apologies, the call came. I have taken too much time. I would like to welcome our distinguished guests, Dr. Omar, Dr. Shirley Lewis, Dr. Deepti Sharma for this meeting. And I also, on behalf of APSL, like to invite all of you to Kyoto. I'm sure Professor Sheena has invited you for the very, very big, large APASL meeting. The theme of the meeting is also on liver cancer. So your coming and joining would be very good for us. And today, the special session on radiotherapy, which has become an important pillar of treating patients with create and other types of cancers, large cancers. So we are here to listen to the experts. Welcome more time to ALCAP and also extending you an invitation to join in Kyoto. Thank you. Over to your moderators. Can you invite Dr. Datta?
Hello, sir. I think there's some technical glitch and Dr. Datta is not able to join. We're just waiting. So I think in the meantime, I can introduce Dr. Omar.
Thank you, Dr. Sharma.
We will be speaking on CERT, the student interstitial radionucleotide therapy in large HCCs.
Thank you. I will share my screen. Just 1 second. So I will talk today about the CERT, selective internal radio therapy treatment in large HCC. I'll provide a case that we previously treated back during my practice in my home country in Egypt. I'm currently working as a consultant hepatologist in Royal Liverpool University Hospital in UK. So basically, my patient was a 52 years old male patient with history of metabolic associated steatotic liver disease. He had a F2 fibrosis on his liver biopsy, and liver stiffness was around 15 kilopascal. So basically, he's not cirrhotic. He has a previous history of schistosomiasis when he was 23 years old and was treated. He presented with incident in the right upper quadrant pain. He had an ultrasound scan to assess his pain, showed a 9.5 centimeter liver lesion in segment 4 and borderline splenomegaly of around 13 centimeter. So a CT scan was requested, and the CT scan at that time confirmed that the lesion is an HCC with a patent portal vein, and he had a small 9 millimeter portohepatic lymph node. His alpha-fetoprotein was 351, and he did not have any comorbidities, and his performance status was 0. So he's quite fit and well in himself. His bloods, as you can see, his blood's almost all normal. Platelets 153, creatinine normal, bilirubin normal. So there's no significant liver disturbance at all. So the patient at the time was thought to be an intermediate to advanced stage HCC. Standard of care at that time was available is around STACE or serafini for these cases at that time, because atezolizumab or bevacizumab was not available at the time. MDT discussion undergone and showed a little bit of concerns for several points. First was the patient is not cirrhotic, but on biopsy, but his spleen was enlarged. It was thought due to probably his schistosomiasis. So there was a query about portal hypertension in this patient. There was as well a query as well about the advanced disease due to the portohepatic lymph nodes 9 millimeter. Despite it is in a NAFLD patient or MASLD patient, it could be just a benign one. However, it was a concern. Further management for this patient at the time, so that the FNA of the lymph node was arranged and it was negative for malignancy. To rule out the clinically significant portal hypertension, a portal pressure study was done, and it showed a portal pressure gradient of 9 millimeter mercury. The patient was rediscussed again in the MDT, and agreement on CERT with a recommendation of high dosimetry of 350 gray. I would like here to stop and reflect on some studies which could help us to discuss our case. So this study, which was about the large HCC, but only up to 8 centimeter, was curative intent using the transarterial radioembolization or CERT. Its legacy study was very important to highlight the role of CERT on those patients with large HCC. And as far as you can see, there is improvement in the overall survival, and the median survival for those patients was around 40 months with large HCC, but it's only up to 8 centimeter. Is another study here showing the role of tear in comparison to resection in large HCCs. However, this one, the median size for the HCCs around 9 centimeters, the median. However, the enrollment for any patient was beyond 5 centimeters. And this study shows clearly that there is no difference in survival or outcomes in comparison to resection if you compare the radioembolization. And you can see here the better safety profile in those patients, specifically about decompensation post-resection. There's several studies here about the dosimetry and the personalized dosimetry of the radioembolization, and all of these studies literally show the standard dosimetry in comparison to the personalized one. If you can see that the personalized dosimetry of radioembolization improved the objective response rate in patients with locally advanced hepatocellular carcinoma. Back to our patient, and you can see here the follow-up and the outcomes as the patient underwent CERT at that time, and there's a quite good uptake of the beads here in the tumor, as you can see in the CT scan, and the patient was followed up after this for 12 months. As far as you can see, this is a significant reduction in the tumor volume. Initially, the tumor size was around 457 cc, and this decreased after 12 months to 61 cc. Further considerations for this patient, discussed again in the MDT regarding consideration of resections or not. And the patient actually at the time was very keen on curative treatment, specifically because he has no background cirrhosis and he was quite keen on radical treatments. So we discussed them again in MDT discussion, and we discussed the patient to avoid any concern, specifically about the residual functional volume or the future remaining liver after resection, if this would happen. And the portal hypertension, one of the CT scans showed basically there is quite concern about progression of his portal hypertension after CERT. And there is a couple of instances and some case reports about the progression of portal hypertension in patients after CERT. However, the pressure studies showed that HVPG is around 10 millimeter, which is borderline, where surgeons are comfortable to do resections, but it is not really that high to show any clinically significant portal hypertension, which probably happens more than 12. So here, reflecting on the some studies that would answer the concerns from the MDT discussions. As you can see, this systematic review is very helpful. It's basically discussing all the studies that show the contralateral liver hypertrophy after radioembolization. And basically, this would provide a safety margin that the future remaining liver will be bigger in size after the radioembolization, which would be more comfortable for resection for those patients, especially if the patient has a big size tumor as our patient. So the summary from these studies, as you can see, the average 3 to 6 months follow-up showed at least 30 to 40% relative hypertrophy in the size of the contralateral side of the liver loops when radioembolization occurs in those patients. So what is the considerations for resections basically on patients with HCC? Usually we'd be worried about the comorbidities. However, our patient is performance status 0, so it would not be any comorbidities for him. So this would be an assuring point. The liver functions, which was been normal as well. And you can assess the liver function by traditional scoring systems such as the MELD score or Child-Pugh score. But there's a lot of debate about the functionality of this scoring system, especially if the patient is not really cirrhotic, and most of them, like Child-Pugh score, is subjective as well. So it's lots of considerations have to be taken here about scoring systems. N-theanine green is one of the most helpful tools as well to assess patients prior to surgery. portal hypertension and the concern about portal hypertension, the pressure studies and HVPG measurement is one of the pillars for assessment of portal hypertension prior to surgery. However, there is non-invasive tools now at the moment. It is a combination of the Baveno criteria for liver stiffness measurement plus platelet count. However, in HCC, how would be the performance of such non-invasive tools, specifically that the platelet count could be raised because of the tumor already, and this would be misleading sometimes. Surgical approaches about the anatomical structure, relation to vasculatures and vessels, as well as the volume of the future remnant liver. Other factors would consider before we think of a patient for resection is usually how many lesions and is there vascular invasion or not. And here comes the difference between different guidelines, specifically from European, American, and Asian Pacific guidelines. As we can see here, the guidelines agrees on some points and has some differences as well. For example, there is no extrahepatic spread is one of the main factors. If the patient have extrahepatic spread, this would preclude the patient for resection. This is an agreement between all guidelines. However, the European one sometimes suggests solitary nodules, but the APASL guidelines usually is more liberal about this, and resectable tumor, regardless the number, tumor size or vascular relations, are usually more liberal in comparison to the European one. As we can see here, there's some agreements about the expected future liver, which are from experts around 25 to 30% in absence of significant fibrosis, or 40% in case of patients with cirrhosis. Sometimes as well, consideration for something like the contralateral hypertrophy through staged portal vein ligation or portal vein embolization or radioembolization could be targeted to improve the remnant size after before surgery. Main thing here as well is the older the patient, the more the complications. So probably older age is could be a concern. However, it is not a contraindication at all in any of the guidelines. And this comes in favor of our patient who is young, fit, with no significant signs of clinically significant portal hypertension. The concern about the functional remnant liver and the assessment of the functional status of the liver, usually the insulin green retention test is very helpful. As we can see, it's in comparison to scoring systems such as Milde score, Child-Pugh score, it outperforms them completely and show better safety margin. Other techniques to target the remnant future liver, and it's usually nowadays a safe standard remnant liver volume through simulated hepatic resection. This is quite helpful. As you can see, in overall patient in this study shows quite good sensitivity and specificity, as well as here on patient with fibrosis only, it's even better. However, it's a little bit worse in case of patients with cirrhosis. So future techniques such as a simulated hepatic resection and reconstruction would definitely help planning surgery, specifically in larger tumors, and targeting the concerns for larger tumor volumes and the small size post-resection. Back to our case, so the remnant future liver is around 35% to 1,517 cc, and the patient is not cirrhotic, as we agreed. The patient has normal bilirubin platelets and decreased alpha-fetoprotein to 8 from 351 after treatment. There is no endoscopic features of portal hypertension. The HVPG was borderline, but no endoscopic features at all. The ICG clearance is normal. Patient had resection and a splenectomy. Coming to the splenectomy point here, there's a lot of studies suggest that splenectomy would as well help the perfusion and increasing the size of the remnant liver, and as a stage prior to with the resection as well would help. The outcome. So this patient had almost uneventful surgery, but minor side effects and complications such as the biliary sepsis and hospital-acquired pneumonia, and both resolved very well. The patient was followed up later and had a tumor-free survival around 4.5 years, and did not show any decompensation post-surgery till the last follow-up. similar to our case, there's a nice study here from 2020. This study shows a liver resection after selective radioembolization therapy and the safety and outcomes in large HCCs. And as you can see, there's quite big tumor volumes here, more than 1,600 cc, which is quite big size. And you can see the outcomes after TERT, as you can see, decrease significantly. And this as well with a change in the function, with a change in the size of the remnant liver after TERT, with increase in more than 900 cc after the TERT, which is proving the idea of that the functional remnant liver volume will increase after TERT due to the contralateral hypertrophy. So this study is quite helpful. It's a series, a case series of around 12 patients or 10 patients. So it's not much, but it reflects similar experience with other centers, similar to our experience. So I thought we would be helpful to raise some points for discussion. As you can see here, the patient selection for TERT is quite heterogeneous, and it's very difficult to see who's basically the best patient. And the key for successful treatment and successful outcome after TERT and for follow-up for surgery is basically dependent on the patient selection. And I think this is the most crucial point here, is the patient selection. The heterogeneity among this target group of patients is very difficult as well, and tackling this heterogeneity with scoring systems and what would be the optimum scoring system to predict the response to those patients is very important as well. So the response of treatment here is still now is not predictable, and there's no optimum scoring system, you can say. What would be the considerations as well as bridging for other therapies, including liver transplantation? There is some case series on this, such bridging techniques, and as well for bridging for resection, as in case in our patients as well. So this points is good for discussion now, and I finished my talk now, and would open the floor for discussions with the panelists and other colleagues. Thank you.
Yeah.
Sorry, please, Professor Datta, please.
Yeah, I'm sorry I'm a little late because there's some issue in the link connection. It was an excellent interactions. Now, I think we can take the questions from the panel, and then we can have a discussion also, and we can have some inputs on different treatment modalities in that.
Yeah. Just one my concern, Dr. Omar, we have SCC with portal vein thrombosis tumoral, where we have limited option for the TARE because of the financial constraints. So we thought of going for the SBRT and TACE. So what you suggest for the sequence? It should be SBRT first or the TACE first followed by SBRT, or the vice versa.
You mean the which would be the best option in case of portal vein invasion, yeah?
Yeah, SCC with portal vein invasion. So we have to go for both the therapies. So which should be first, TACE followed by SBRT, or SBRT followed by TACE?
I think SBRT would be better than TACE, but the SBRT will have a limitation about the doses, and you will not be able to go very high doses. So sometimes you can still go with TERT sometimes to help to give more doses with TERT. So selective internal radioembolization would be a better option. But if it's not available, then the external radiotherapy probably will be a good option here in comparison to TACE.
So, sir, excellent talk. I just want to know, in this patient, there was no portal vein tumor thrombosis. So, in the patients with large tumor with the presence of PVTT, means VP2 or VP3, then what will be your approach for the patient with large tumor and portal vein tumor thrombosis, VP2, VP3?
I guess according to the response to treatment, you probably can go up to 3 years, but it depends on the response to treatment from the first 2 cycles. So I would go for the 2, and then if there is good response, that would be enough. But if there is no enough response according to modified RECIST criteria, then you can proceed for another cycle as well sometimes. as well as it depends on how his performance after the liver function, the response to treatment, how is the general condition after first 2 cycles. So you just can't go for 3 cycles and the patient is not really experiencing any side effects. That's fine. If the patient is experiencing side effects, the deranged liver function test, then I think then we have to stop and consider other alternative options.
Yeah, Dr. Omar,
yeah,
what we see in India, that large tumors usually have portal vein involvement. So in that case, if you plan for the SBRT for the portal vein and trying to operate and recanalize it, followed by tear or TACE, depending on the availability. So what do you feel, that whether it is an option, or you want to have a tear first or TACE first, and then the portal vein part you can take place later?
I guess it is experiences from our center and as well from other centers, and there's published studies that the CERT or TEA will help with the partial portal vein thrombosis. So I think if we would go directly to TEA or CERT would be a good option. But if it is not available, then I would go for the SBRT, then followed by TACE then. So if it's available, so initially I would go for CERT first. If it's not available, then SBRT will stay.
And suppose what complications means the type of complication that RILD, how often you see RILD in these patients, large HCC with undergoing CERT?
From our experiences, like it happens, but like I don't have a specific number, but not that common. So I can have a look for specific numbers in comparison to the total treated numbers, but I don't think it's not that common for our experiences. But as far as I can see, we started here in the UK only the CERT quite recently. So CERT is not here in the UK for a long time. But back in Egypt, we did have the TEAR for longer time, and our experiences was very good.
Thank you.
Excellent talk. We just wanted to ask, which is the largest size tumor that you have treated with CERT? And is there any constraint or any normal liver? What should be the volume? Is there any constraint for that?
So I will divide my answer for 2 points. Here in the UK at the moment is a different practice from back we used to do in Egypt. So in the UK, it is currently it is advisable for patients who is not for resection and not for systemic therapy. So this like because of concerns of portal hypertension and other complications. So basically, it's limited for a specific group of patients in the UK. With size probably is not a limitation. So the maximum we had here is 11 centimeter. But we going from other perspective from Egypt, where we did use TEAR for longer time. It was a referral center, transplant center. Doing TEAR for almost 15 years or 10 years. So the experience was a little bit different. So we did treat tumors up to 14 centimeter, but it was not a primary liver cancer. Sometimes it was metastasis as well. So TEAR and CERT was being used as well for other liver lesions, not only HCC, and did show quite helpful results as well. Here in the UK, another indication other than the HCC is the colorectal metastasis. So the colorectal cancer metastasis is very common, and it is usually treated with CERT as well. And this has been going beyond the liver one. So this CERT was indicated for colorectal cancer metastasis if it's a single metastasis in the liver for almost since 2017. But it's only been approved recently in the UK for primary liver lesions, and it's now, like I say, categorized for a specific group of patients who are not fit either for surgical resection or for systemic therapy. And is used as well as a bridging technique with other combination therapy.
I think there's one more question in the chat box as what about the immunotherapy in the cases of portal vein tumor thrombosis? So I'm
not sure what he means about this, but it definitely, if the patient has portal vein invasion, systemic therapy will be having a good response. And in this patient, he did not have portal vein thrombosis, and at the time of the diagnosis, this new systemic therapy was not available, and the only thing was available at the time was sorafenib, which will not perform well at that time. So at the moment, the systemic therapy patients, any patient with portal vein invasion, probably would, if the liver function is okay and there is no clinically significant portal hypertension, we put them for atezolizumab and bevacizumab regimen, and this is quite established here in the UK. If the patient did not have any contraindications, like I said, specifically clinically significant portal hypertension and preserved liver function test with portal vein invasion, then directly go for systemic therapy.
I think in India, we used to go for, as for the BCLC guidelines, the systemic therapy is the treatment of choice. But here, what we are doing the local regional therapy in the form of SBRT followed by systemic therapy. So it is giving a good local control and in turn leading to increase in the overall survival of the patient.
Yes, there is some patients. It's based patient by patient, and sometimes we do in combination. So if there is a suspicion of for example, advanced disease in a patient with a single large nodule or a single large tumor, then probably you can do, for example, TARE or CERT plus systemic therapy if there is such thing. But if there is multiple foci and the patient has multiple small lesions, probably local regional treatment will not be the best, and then systemic therapy alone will be the choice. But if this, for example, is a patient like my patient that presented today, but have a portal vein invasion, then would be probably combination therapy of CERT plus systemic therapy.
Yeah. Thank you so much, sir.
Thank you.
So, other question? No, then we can move to the next session. I'd like to welcome our moderator, Dr. Devnarayan Datta. He is Head and Senior Consultant, Department of Radiation Therapy, School of Medicine, Kochi. So over to you, Dr. Datta.
Thank you for inviting me in this session, and I think it's nice talk and good interactions happen by Dr. Omar. And so we can actually call the next speaker, and we take the question and answers after the session.
Yes. So whether my slides are visible?
Yeah, it is visible. Yeah, Dr. Sharma.
So I'm Dr. Deepti, and I'll be talking on the radiation therapy for HCC, the implication and way forward. So the heading in which I will be discussing is the introduction of SBRT, the role of SBRT or radiation therapy in different stages of these as per the BCLC guidelines, and the evolving role of biomarkers. So as we all know that liver per se is a radiosensitive structure, and a dose of 30 gray at a fractionation of 2 gray per fraction results in fatal RILD even in cases of non-cirrhotic liver. And per se 30 gray is a very less dose if we talk about the ablative procedures. So therefore, before 1990s, radiation therapy was used as a palliative measure. Then came the concept of partial liver irradiation, means the liver substructures are arranged in a parallel fashion, and if we the liver to a higher dose, even then we can reduce the chances of RILD by sparing the dose to the remaining part of the liver. Then further, with the advances of technology and conformal radiation therapy in 2005 onwards, there comes the SBRT era, and we are using radiation therapy as one of the modality for the treatment of HCC. So SBRT is defined as a conformal radiation therapy with respiratory motion management under image guidance, and we have to deliver very high doses up to a dose of 40 to 50 gray in 3 to 5 fractions so that we can increase the biological equivalent dose. And the aim is to increase the tumor control probability and at the same time reduce the normal tissue complication probability. By conformal radiation therapy, we need to align our multi-leaf collimator in the machine with the tumor geometry so that to reduce the chances of dose spillage to the remaining part of the liver and other organ at risk. For the respiratory motion management, either we use 4D CT to assess the tumor motion, or the techniques which can be used to reduce the motion are abdominal compression and breath hold technique, and to reduce the impact of motion of target, we can use tumor gating or tumor tracking. So actually where radiation therapy fits in as per the BCLC guideline. So as per the BCLC guidelines, the treatment of choice for early stage HCC is liver resection or transplantation or ablation. So those patients who are unsuitable for resection, liver transplant or ablative procedure, they can underwent SBRT, or it can be used as a bridge therapy. In the large HCC or the patient with PVTT, we can use SBRT in patients who are ineligible for TACE or in the combination of TACE as a downstaging procedure, or in the presence of PVTT, we can deliver dose to the PVTT to recanalize the tumor thrombus. And again, it can be used in the recurrent or settings after other loco-regional therapy. So now the role of SBRT in BCLC A and B. So these are the few prospective phase 2 studies of SBRT which have been done for early HCC. The tumor size ranged from 1 to 3 centimeter, and there is a local control of more than 90% in majority of the studies. And in this study by Matthew et al., 297 patients were included. And these patients were ineligible for other modalities, and 40% were heavily treated. So in this group of patients, the overall survival is 77%. And the authors also concluded that the patient with child's AFP of less than 10, ECOG of 0, and those patients who underwent liver transplantation after SBRT, they had a better overall survival. Further, in this systematic review by Shankar et al., published in 21, 49 studies were included for small HCC, and the pooled 3 years local control and overall survival was 84% and 48%, with a grade 3 toxicity of 6.5%. And they have also concluded that by increasing the prescription dose of 1 gray, there is a local control and overall survival prolongation by 0.36% at 3 years without compromising the liver function. SBRT can be used as a bridge to liver transplant. So in these retrospective studies where SBRT has been used as a bridge to liver transplant for the size ranging from 2 to 4 centimeter, a pathological response rate of 25 to 100% has been achieved. So as we know that as per the guidelines, TACE or RFA is usually considered as a bridge procedure. So in this trial by Suyochen et al., they have found that the patients who are ineligible for other modalities of treatment, so they underwent SBRT followed by liver transplant. So in this trial also, the 5-year cumulative risk of recurrence after the liver transplant was 26% in SBRT group, which was less than that of the recurrence in the TACE group. Also, the 5-year survival from the time of listing was comparable in the 3 groups. So as to one can conclude that SBRT can be considered as a bridge to transplant. In the patients who are radically treated by RFA, so again, in those group of patients where the patient underwent SBRT, as RFA was not feasible in this group of patients. So in this study, they have found that the SBRT has resulted in a better local control. Even after the propensity score matching, the curves are separated far apart, showing a good local control in the SBRT arm. And the authors suggested that the SBRT is an effective alternative to RFA, especially for the larger tumor more than 3 centimeter with subphrenic location and post-stage recurrence. Similarly, the SBRT can be considered as a modality of treatment for unresectable early SCC. And in these studies, again, when we have compared SBRT with TACE, so there is a good local control at 2 to 3 years, and the survival is somehow comparable in the two groups. Now, the role of SBRT in BCLCC. So as we all know that BCLCC is mainly characterized with the presence of metastasis or tumor thrombosis. And in the studies have showed that the presence of thrombosis leads to decrease in the overall survival. So the intent of treatment by SBRT in the patients with portal vein tumor thrombosis is mainly to recanalize the portal vein so as to facilitate other loco-regional therapies and to reduce the chances of complications. Decompensation. With SBRT, there's a response rate of about 54% in this group of patients, and the recanalization rate is about 50% to 75%, with a grade 3 toxicity of less than 5%. Further, in the presence of PVGT, that is especially VP1 or VP2 thrombosis, radiation therapy has been used as a neoadjuvant modality before surgery. And in this trial by V et al., when the upfront surgery was compared with neoadjuvant radiation therapy, there was an improvement in the overall survival and disease-free survival in the patient who underwent neoadjuvant RT. This is one of the series which has been published from India. So in this, the patients with VP1 to VP3 tumor thrombosis have been downstaged with the help of TARE and TACE and radiation therapy. And what the authors have said, observed that the 5-year overall survival in the disease, in the downstaging arm was better as compared to the non-downstaging arm. So these were the studies in which radiation therapy was used before surgery or liver transplant. So in the patients who are ineligible for surgery or resection, so these are the studies in which radiation therapy has been used as a radical modality. And there is a disease control rate of about 80 to 90% in all this group of studies. And with a progressive disease was seen in about 10% of the patients. So this was a study from Dr. Datta only has done the study, and in this again, the complete response and partial responses is to the tune of 70%, with the overall survival at 1 year is about 38 to 50%, and the median overall survival ranges from 9 months to 13 months. The presence of inferior vena cava tumor thrombosis is usually considered as a fatal disease with a fatal results. So in the patients with IVC tumor thrombosis, where the thrombosis has reached the right atrium, SBRT again has a role and can easily treat this group of patients with a good survival ranging from 9 months to 18 months. So this is our SBRT experience from ILBS. We have treated 108 patients with either PVGT or inferior vena cava tumor thrombosis. About 45% patient had nodal metastasis at the time of presentation, and distant metastasis was there in 30% of the patient. So at the median follow-up of 13 months, the median overall survival was 14 months. 1 year overall survival is 58%. Local control at 1 year is about 90%. Median progression-free survival is 13 months. And median intrahepatic recurrence-free survival is 12 months. This is one of the case that we have treated, the case of infiltrating HCC with portal vein tumor thrombosis, and you can see it's a large HCC involving the segment 7, 8, 4, and the portal vein tumor thrombosis is up to the confluence of the splenic vein with a very high alpha-fetoprotein and PIFCA of 6400. So patient was treated with radiation therapy to the entire liver lesion and the portal vein tumor thrombosis. And this is a PET scan which was done after 2 years. So the patient was started on radiation therapy followed by TKI with lenvatinib, and the patient is doing well even after 2 years. This is another patient that we have treated with large HCC, left lobe lesion with VP4 tumor thrombosis. The right portal vein was also involved. And because of the proximity to the stomach, we give lower doses to the organ nearby structure. And to prevent the dose and prevent the RILD, we reduce the dose to the portal vein of the right side as well. And so this is the follow-up scan, which is done after about 3 years, and patient is doing well without any complication. So the role of SBRT is whether we can combine the two modalities of locoregional therapy. So the answer to this question comes from these two systematic review and meta-analysis, where SBRT with radiation therapy was compared with TACE alone or radiation therapy alone. And in both the two meta-analysis found that the patient who underwent the combination therapy, they had a better overall survival and local control. This is one of the case which we have treated by the sequential therapy, large lesion in the segment 5, 8, and 4. And the patient underwent 3 sessions of TACE, followed by radiation therapy SBRT to a dose of 35 gray to the core of the tumor. And the periphery was treated by 30 gray in 5 fraction. This is a scan post radiation therapy 6 months. Patient is doing okay, and this is the follow-up scan of at 2 years. Clinically, no diseases there. So, so the radiation therapy is a part of locoregional therapy, and we can combine the TACE with radiation. But what should be the sequence? It should be a radiation therapy first or TACE first. So, in this randomized control trial, Gu et al. Has found that the patient who underwent radiation therapy first, followed by TACE, they had a better overall survival and progression-free survival as compared to the patient who underwent TACE, followed by radiation therapy. We at IBS also found that the patient who underwent SBRT first, the chances of decrease in the size is more in the first 2 months, and then the patient can undergo TACE and with the good results. Now, as per the guidelines, the treatment of choice is systemic therapy. So is there any role of locoregional therapy, adding locoregional therapy to the systemic therapy? So the answer came from the RTOG 1112 trial, where the sorafenib was compared with SBRT followed by sorafenib. And in this, the median overall survival has increased from 12 months to about 16 months in the combination arm. And similarly, the median progression-free survival increased from 5.5 to 9.2 months. Now, the combination of TACE, sorafenib, and radiation therapy, all three in one group will be doing better, and the same results is from the Liu et al. Trial, with the increase in overall survival to 9 months when the combination of TACE, radiation therapy, and sorafenib was used, and similarly, there is an improvement in the progression-free survival. Proton therapy is a newer technique which is being used other than the photon therapy. So the proton therapy is working on the principle of Bragg's peak, that is minimum exit dose. So these are the color washes of a photon therapy, beam therapy, and proton beam therapy. So as we can see that in the proton beam therapy, the spillage will be less. There is no exit doses. So lesser chances of RILD. And because of this, we can increase the dose prescription to the tumor in case of proton beam therapy, and lesser number of lesser chances of RILD in this group of patients. And if we are increasing the prescription doses, then yes, we'll get a better overall survival in the patient who underwent proton therapy as compared to the photon therapy. MRI-guided SBRT is newer technique and is being used for the real-time visualization of the anatomy, online adaptive radiation therapy, and motion management, and is often used in the cases of re-irradiation of the liver. These are some of the studies which have been have used MRI based SBRT, and they have found that the response at 1 year is about 90% to 100%. Now, the combination with immunotherapy, there's a synergistic effect of SBRT with immunotherapy. So radiation therapy results in the new antigen formation, which in turn results in radiation-induced antigen-presenting cell maturation, T cell recruitment and mobilization, and which in turn leads to tumor cell sensitization to the in the cells. But at the same time, there is upregulation of PD-1, PD-L1, and CTLA-4. There is increase in the infiltration of Treg cell as well, which are the immunosuppressant cell in the tumor. So there is an escape of tumor from the immune surveillance. And that is why there came the role of anti-PD-1, anti-PD-L1 immune checkpoint blocker, so as to increase the impact of the immunotherapy. So these are the few studies where the immunotherapy has been used along with the SBRT. So in this study, only 5 patients were treated. And of the 5 patients, SBRT was followed by anti-PD-1 inhibitor, that is nivolumab in this study. The complete response was there in 2 patients and partial response in 3 patients. 1 year local control was, and overall survival was 100%. In another study by you et al., in which nivolumab was used, so the patients who underwent radiation therapy either before nivolumab or concurrent with nivolumab, they had a better overall survival and relapse progression-free survival as compared to the nivolumab alone. This is one of the patients which we have treated for the large tumor along with the nodal metastasis by the radiation therapy, followed by nivolumab therapy. The scan, this is post 30-month scan, which is showing a response at the primary site as well as the nodal site. So nivolumab is an anti-PD-1 inhibitor and ipilimumab is an anti-CTLA-4 inhibitor. So if we combine the 2 IOs, so it will result in a better overall survival. Then again, the use of SBRT with IO therapy will leads to increasing in the overall survival and disease-free survival, which can be by these plots. That the overall survival is about 57% in the IO group as compared to the 50% in nivolumab alone group. The median overall survival is 41.6 months versus 4.6 months. But there is a higher toxicity of 72% in the doublet arm as compared to only 50% in the patient who received nivolumab. So again, in a START-FIT trial, they have used TACE with radiation therapy and immunotherapy. So in this group of patients, 33 patients were recruited with advanced HCC. On day 0, TACE was delivered, followed by SBRT starting from day 28. And then avelumab was started, which is an anti-PD-1 inhibitor, every 14 days. And at the end, it was found that 55% of the patients were amenable to the curative treatment, 2 underwent resection and 2 RFA, and there was a radiological complete response in 42% of the patients. The median overall survival was 30 months and the median progression-free survival was 20.7 months. So next came the question whether SBRT and immunotherapy should be considered as a first-line therapy or it can be used as a second-line modality as well. So in this trial, the SBRT with immunotherapy was used as a second-line modality after other loco-regional therapies and after progression on TKIs. So in this trial, the radiation therapy was delivered, followed by pembrolizumab, starting from the day 1 of SBRT and every 21 days. And there was an objective response in about 50% of the patient, and the disease control rate was there in 67% of the patients, with a median overall survival of 14.2 months. Now the evolving role of biomarkers. So the biomarkers help in the early differentiation of responders and non-responders. It helps in the personalized treatment. We can find out the PGL1 concentration post-radiation therapy so that we can customize our treatment and the circulating tumor DNA. So this is an abstract which was presented by us in ASLD in 22. And what we have found that after radiation therapy, there was a sustained PD-1 and LAG-3 expression post-SBRT. So especially in the hepatitis-related patients. So means post-SBRT, there is a persistence of the PD-1 receptors, and so these patients are going to respond through immunotherapy better as compared to those who has a decrease in the PD-1 and LAG-3 inhibitors. Also, by this we can find that in future we can have more anti-LAG-3 inhibitor, LAG-3 receptor antibodies as well, so as to customize the treatment. In another pilot study, we have taken the sample pre-SBRT and post-SBRT, and what we have found that in these patients, the cell-free DNA has reduced post-SBRT, except in 2 patients, which when we have seen with the progression-free survival. So we have found that the patient in whom the cell-free DNA has increased post-SBRT, they had a poor progression-free survival as compared to those in whom the cell-free DNA has reduced. Similarly, this is unpublished data from ILVS, and we are going to present in upcoming APASL the prognostic role of HGF and VEGF in advanced HCC. So in this also, we have taken the samples of patients before SBRT and after SBRT, and what we have found, the patient in whom the HGF factor and VEGF factor has increased post-SBRT, the progression-free survival is less, that is 6 months and 9 months in VEGF and HGF factors, and in whom the patient, the VEGF is reduced, the progression-free survival is increased to 14 months. So means HGF and VEGF can be used as a prognostic for early detection of the disease. Hexokinase 2 is another modality where we can use the hexokinase as a factor to find whether the tumor is, whether there is radio resistance or not. So it has been found that the upregulation of hexokinase 2 results in radio resistance. And in the study by Zhang et al., it has been found that the patient who had hexokinase 2 upregulation, they had a poor overall survival as compared to the patient who had hexokinase 2 downregulation. So in the last, there's a mathematical model by Zhang et al., and what they have found that in the patients of large advanced HCC with metastasis, so if we give radiation, even the low dose of radiation to multiple lesions, including the metastatic side, this will result in a better progression-free survival. So in the study, they have found that when they treated with ICI alone, the progression-free survival was less. But when we have treated the tumors along with the metastatic side, multiple lesions with ICI, there is an improvement in the progression-free survival. So to conclude, SBRT is a safe, feasible option for all the stages of HCC with high local control. Optimal integration of radiation therapy and immunotherapy requires more investigation and a comprehensive understanding of the tumor ecosystem. So at the last, I can say that SBRT is a ray of hope for liver patients and liver tumors. Thank you.
Thank you, Dr. Dipti, presentation, and you have covered the entire gamut of radiosurgery in liver. So anyone has any question? We have a lot of things to ask with Dr. Dipti. Yeah. Dr. Dipti, do you follow this that adaptive dose prescription model by Dr. Roshan, or you have a different model of prescription of dose for this for ACCs?
So we usually follow the dose prescription as per the Laura Dawson, Dr. Laura Dawson. So, but in the patient with very large HCC, where it's very difficult to push the doses and prevent the RILD, sometimes we reduce the doses and mean liver dose to 13 gray, not 15 gray in such group of patients. Because here what we see routinely is the child's B7 or LB grade 2. So such group of patients usually do not tolerate up to a dose of 40 gray. So sometimes we used to reduce our doses to 35 gray. We treat by SIP technique, means higher doses to the core of the tumor, and the periphery we treat by 30 gray or less than that. Means 80 to 90% coverage to the PT grays.
What is your the classic RLD in your patient cohort? Because usually it is around 10% to 14% in the entire cohort. Right? Classic RLD.
So classic we are not finding. We are mainly finding the non-classical RILD, where there's increase in the bilirubin or increase in Child scoring by more than 2 points. And but generally these patients improve with time in the next 1 or 2 months. And we usually give supportive treatment for such patients, mainly with the albumin infusions and fluid mobilization. And means the RILD is less than 5% in our group of patients, because before taking the patient, the aim of in our patient is to increase the local control, and at the same time we have to continue with the systemic therapy. So sometimes we reduce the dose of radiation therapy so that the patient remain fit for the systemic therapy, because like what I have shown you, in our group of patients, about 30 to 40% are metastatic. So this group of patients really need systemic therapy. So the plan is like local regional therapy followed by systemic therapy to be started as soon as possible. So sometimes we reduce the doses to 35 gray to the tumor, not going up to the 40 gray.
Yeah. So one thing, what kind of image tracking method do you use, or what is the PTV margin you use?
So PTV margin is 3 to 5 millimeter, and we have 4D CBCT in our department. So earlier, means either we use abdominal compression or breath hold techniques, followed by 4D CBCT. In case we are using the breath hold techniques, in case we are using the abdominal compression with 4D CT scan for the planning, and then we use a 4D CBCT for the tracking, for the assessment of the motion during the radiation therapy. If we are using the breath hold, then we are using the
any fiducial you put, or you don't put fiducials in this?
No, sir, we are not using a fiducial. So in the patient who earlier underwent TACE, so the lipidol works as a fiducial itself. And in whom we are upfront going for radiation therapy, we are not using fiducial because of the high risk of bleeding, because the patient which we are having are mainly B7, A6 to B7, not A5.
Yeah. Okay, thanks, Dr. Diti. It is an excellent presentation.
Thank you, sir. Any other question?
A nice presentation. Hi, sir. Can I ask a question?
Yeah, sure.
Yeah. So are you, in case of patients with B7 or B8, do you use any adaptive form of treatment, like giving them one or two fractions and then giving them a break and then reassessing? Have you ever done that?
Yeah, we have done in couple of patients. Like especially we take we do go for ICG testing, especially if the ICG is more than 15 and we are not achieving the mean liver dose of 15 gray. So either there are two ways: either we fractionate the treatment, not giving the entire treatment in 5 fractions, but we increase to 8 to 10 fractions of radiation therapy, or we deliver 3 doses of radiation therapy followed by a break, reassessment after a month, and again start the treatment for the remaining 2 fractions after replanning. And we have seen good result with that as well. And in few patients, we have treated with just single fraction of radiation therapy followed by systemic therapy, and then patient came again after a month. So again, a palliative dose of 8 to 10 gray. So it is also working, especially in patients with very large tumor with a remaining liver volume of less than 400 cc, 400, 500 cc. So these group of patients are also responding well. Especially the symptoms have improved in this group of patients. Just for the palliative purpose.
So thank you for the presentation. I would like to ask, what is the maximum percentage of reduction in tumor size you have seen among your patients? And is there any maximum dose that you would recommend not to go beyond?
So, it's actually the size reduction takes time. It is not within a month. So with time, it reduces to more than 25% of the actual size. But it takes about 6 to 9 months or more. So if we find that there are any other lesion or the periphery, then we go for the other loco-regional therapy as well. We generally don't want these to reappear. And generally we start with, because the patients which we are finding are with PVTT. And for with PVTT, the treatment is systemic therapy. So we have to start with radiation therapy and start systemic therapy also. So we generally start systemic therapy with TKI within 10 to 15 days. And if we are going for immunotherapy, we generally start by 21st day, if the LFTs are okay.
Thank you.
So any other question? Otherwise, we'll move to the next session.
I have a question. This is Dr. Payawan.
Yes, sir.
Can you hear me? Yes. Do you have any stopping rules to say that this therapy doesn't work? Do you have a strategy where you can say that you have exhausted the therapy and maybe not go on anymore?
So please repeat the question. Your voice is cracking.
Do you have a stopping rule? In other words, a simple strategy for us clinicians to say that this therapy might not work and maybe other strategies can be tried on?
So, Ms. whether the therapy is going to work or not, if I'm not, you're asking this question?
Yes, sir. Yes, ma'am.
So, sir, like we have done a pilot study at our center. So, here we are finding the HGF measure the immune cells in the blood plasma after radiation therapy. The results are yet to out. We are doing the prospective analysis as well. So we are finding that the changes in the immune parameters post radiation therapy. So in hepatitis related HCC post SBRT, there is an increase in the PD-1 expression. And what we have seen in the patient with NASH related HCC, there is decrease in the PD-1 expression. So what we can say that this is a pilot study, but with this result, we can say that the patients with hepatitis related HCC, they are going to do better with immuno checkpoint inhibitor as compared to those with NASH related. And I think same results have been shown by different studies as well, where they have found that immunotherapy is a better modality for hepatitis related HCC. But our results are preliminary and we need to analyze more data on that.
So, Dr. Deepti, how many percentage you see as hepatitis related, and how many are NASH related? In Kerala, most of our patients are NASH related. We don't see too many hepatitis.
No, it's that there's just a reversal. So about 60% are either NASH related or alcohol related, and less than 40% are hepatitis related. So now especially the young patients who are coming, they are usually hepatitis related, but elderlies are majority are NASH related or alcohol related. So that there is a change in the etiology of the HCC at present. So any other question? Otherwise, we can move to the next session.
Yeah, I think it was an excellent discussion happened. I think we can shift to change the next presentation.
Yes, sir. So, Dr. Datta, please invite Dr. Shirley for the next.
Yeah, can you introduce Dr. Shirley? Shirley is a good friend of ours, and she is very good in in liver tumors. Dr. Shelley.
Hello. Can you hear me, and can you see my screen as well?
Yeah, we can see you, and you can see your screen as well.
Okay.
Hi, Dr. Shelley. Welcome to this.
Hi, sir. How are you? So I thank everyone for giving this opportunity to present about RILD today. I think Dr. Deepti has excellently summarized about radiation, especially role of SBRT and its integration with other modalities as well as a single modality. And I have the opportunity to talk about radiation-induced liver injury, the prediction, prevention, and therapy. And this was or likely is still to be a more feared complication of radiation to the liver. Now, we know that SBRT is an acceptable treatment, but what has been a deterrent to development of SBRT as one of the main treatment modalities for HCC was the risk of toxicities, especially radiation-induced liver injury. And in the older series, we have an incidence of anywhere about 10 to 15%. But now with more understanding of the dose, the response, as well as how much of liver to be spared, the modern series, the risk of RILD has come down significantly, and they're in single digit to be less than 5%. What we know is that liver is definitely a very radiosensitive organ, and based on the etiology, when there is pre-existing hepatic dysfunction, particularly in the form of cirrhosis due to various underlying causes, it will compromise the tolerance to radiation. They tend to become more sensitive, and in those cases, I think planning radiation would be very, very important to take care of the doses that we deliver to the rest of the liver. And so when we deliver radiation, the toxicities from SBRT can be classified into liver, GI, biliary, or chest wall toxicity. Today, for the interest of the talk, I'll be limiting to liver or the biliary. And usually the classic RILD, now the chances of that happening has become less than 5%, whereas a non-classic variety where you only see Child-Pugh changes by maybe 2 points, maybe ranging from 10 to 30%. And it definitely depends upon the Child-Pugh status. We will be looking into literature on that. And the biliary incidence, like in the form of stenosis or obstruction, could be seen in 5 to 15%. The older series show a higher percentage because initially it wasn't considered, and high doses could have gone to the central biliary tree. But in now recent series as well, this has been lower. So in case of acute toxicity, that is during and immediately after SBRT within the 3 months, at best what we may see is some temporary changes in the blood work without any much symptoms. And what may be important would be to monitor these patients, like have a proper baseline blood workup before and maybe 2 weeks after SBRT. And we would look at mainly changes in liver enzymes, and these changes are often transient. And so the hepatic dysfunction that most often that we end up seeing may be slight transient change in bilirubin, AST, ALT, changes which are the rise in AST or ALT. Now, I technically don't in a 5 fraction SBRT or 3 fraction SBRT do a midweek or mid-treatment assessment. Would do probably pre and then 2 weeks post. And so, of course, that patients is already in acute hepatitis, you wouldn't be going ahead with SBRT treatment in the first place. And even the choice or the selection of the cases is usually only up to the Child-Pugh B7. In maybe in those with B8 or B9, you may go ahead, but may not go ahead at one go in 3 to 5 fractions. What is important to know is that if you are seeing any changes in the liver enzymes, then it's better to hold on till the liver enzymes normalize. In terms of late toxicity, RILD is the main toxicity that we fear in addition to central biliary toxicity. Now, coming to the RILD incidence with the more modern series of SBRT, this is a very recent review from the International Stereotactic Radiosurgery Society, which has summarized and looked at overall 17 studies from 2003 to 2019 and demonstrate very excellent overall survival and local control rates. What is more important here is that in these series, they found that the classic RILD was almost negligible, 0% ranging from 0 to 2%. 0 to 2%, and non-classic RILD rates were about 8%, about 5 to 12%. So these all, the risk of toxicity has come down significantly. And in their recommendations, when they talk of, they also clearly mentioned the classic RILD is now a very rare event. This is important to realize because previously radiation was not even offered to patients thinking that they would fail and cause liver failure. This is a very recent trial comparing proton versus TACE in patients who are meeting the transplant criteria as a downstaging, and it compared proton in 15 fractions versus TACE. And in terms of toxicities, I just bring this out, this trial to show the toxicity rates of proton versus TACE. Of course, we know Deepti showed that proton beam therapy, the exit doses are very less, so you could probably spare the liver excellently, and this is very well reflected also that the chances of having a grade 3 or a grade 4 rise was just about 2 to 5%, whereas probably higher with TACE when compared to proton beam therapy. Some of the contemporary series, what's important now to see is that the chances of grade 3 toxicities are very low. Most people show that there are changes in the form of child fluid status. And even grade 3 plus toxicities are only like 2 to 3%. What about larger tumors? In larger tumors, like the most important series from Princess Margaret, they've shown that the grade 3 toxicities can be as high as 30%, and these are primarily the non-classic variety. They, despite having large tumors, none of them actually had an IRLD because very strict planning and conformal planning doesn't result in IRLD anymore. And the other study, which also showed that the grade 3 toxicities could be anywhere up to 17%. Coming to the RTOG 1112 study, still to be published in a full text form, but when they compared sorafenib addition with SBRT, the toxicities were very comparable. And even in terms of hepatobiliary disorders, if you see that addition of SBRT to sorafenib did not worsen the toxicity profile in these cases, which is very, very important. Now, coming to RILD proper, RILD is radiation-induced liver disease or injury, and this can be classified into two types, that is the classic and the non-classic variety. Classic variety, there is no prior history of liver disease, and these patients often present with fatigue or abdominal pain, increase in abdominal girth with anectric ascites and hepatomegaly. What is very characteristic is that most of the liver function is going to be normal, and it's usually the disproportionate increase in the ALP, which is C. Now, this has been described that this could happen anytime between 2 weeks up to 3 months post SBRT, and the risk has now come down significantly. What we now commonly see, especially in those with hepatitis B or C or even alcohol cirrhosis, we will see changes in the liver enzymes or decline in the liver function. And this decline in liver function can happen at 3 months and sometimes even later up to 1 year or 18 months. And these slight changes are transient most of the times, and they completely recover with good medical management. And so these are not permanent toxicities that are seen, and the rates could range from anywhere between 20 to 30%. If it is a very classic RILD, would result in liver failure and lead to death of the patients. So non-classic RILD is what we would classically see, and that's why monitoring or seeing these patients with CP score or NALB grade, pre, post, and monitoring them would be more crucial. Coming to pathophysiology, we know that there are a lot of lot of pathway markers which get elevated, inflammatory markers, particularly after radiation. And these are released not just from the hepatocyte, but usually by the supporting cells like the Kupffer cells or the reticular endothelial cells. And they get activated by the various factors released from the endothelial cell. And the typical picture of RILD that is seen is in the form of a veno-occlusive disease. Now, what you see here in the picture is wherein the central venule gets completely destroyed, and you see that there is endothelial cells and there are lakes of erythrocytes which get accumulated. So there's a lot of congestion in the liver, and there's also loss of hepatocytes resulting in, and also these inflammatory cytokines release a lot of fibrotic material. So that's going to result in a form of a congestion. And where there is probably a more higher dose, you may see different zones after SPRT. And like in the central part, there may be even necrotic, where the cells or the tumor cells are dying. And in the second phase, where we see fibrosis, veno-occlusive disease is probably seen more at the junction of the normal tumor as well, normal liver with the tumor. And so this is how it shows that there are changes in the liver if one would operate these patients and see what are the changes that will be seen in the liver. Now, this is a nice review in the cell cycle where they have described about the various pathophysiology of RILD that can be seen. And in a normal healthy hepatocyte, when after radiation, there are certain factors released which will activate the both the stellate cells as well as the Kupffer cells. So what happens is that there is a lot of inflammatory cytokines which get released, and there is a cascade of cells. So that's what we see, is that there's transforming growth factor beta, there is tumor necrosis factor alpha. All of these are going to increase amount of fibrotic material which get deposited, at the same time recruit more and more inflammatory cells there and result in leaky capillaries, and there are a lot of erythrocytes which get accumulated there. In non-classic RILD, technically, it's usually a different form of a pathophysiology. So here it more is related to stellate cell activation, no doubt, but there is more of mitotic catastrophe of the regenerating hepatocytes likely, and there is reactivation of hepatitis B as well. So what happens is there are still some interleukin 6 is one of them, which is activated more from the endothelial cells, and this could cause reactivation of hepatitis. Of course, we know that patients who are undergoing any form of liver-directed therapy, they are seen by hepatologists, and hepatitis B titers as well as treatment is initiated sooner for these patients. So what may be the predictive factors which will cause increased risk of RILD or liver injury post SPRT? So in patient-related factors, I would say that it's usually the larger tumor, because when you want to give a higher dose to the liver tumor and spare, it may not be always feasible. The baseline functions of the Child-Pugh status, whether it is Child-Pugh A versus B, pre-existing cirrhosis, presence of portal vein thrombus, all of these may be a contributory factor for injury. In terms of treatment factors, concurrent use of chemotherapy, whether it is hepatic artery infusion, which was used initially, or combination with sorafenib during the SPRT days, is something that is shown to cause increased risk of liver injury. Maybe even combination with TACE could also increase the risk of injury. In terms of radiation planning, what is very important is what is the volume of the liver which is going to be spared, what is the mean dose to the liver which is spared, how is the technique of radiation delivery, and also the dose per fraction. So it is known that the liver is radiosensitive, and among the radiosensitivity pattern, we say that it is a parallel architecture that liver has. So we believe that liver, as long as we are able to spare a certain volume of the liver, which we can keep to a very low dose, we could minimize the risk of a global functional compromise. And at the same time, we also know that liver has regenerative capacity, so it could have some amount of regeneration despite the cell loss as well. And so if we look at different series which have treated with SBRT, they have tried to look at various factors which could predict the risk of toxicity. This is one of the studies by Jung et al., where they've given higher doses, almost like 10 to 20 gray per fraction. And in this series, interestingly, that the grade 3 RILD was seen in only about 6.5%, and the non-classic variety where grade 1, grade 2 changes were seen in majority of the patients. And what they found was if there was a chance of grade 2 or worse liver injury, it is usually the baseline child-PU class which has a significant impact. That is whether you are a child-PU A or B. And this was also seen in a similar phase 1 trial where they saw that when they were treated with 3 fractions. So there's a phase 1 dose escalation trial. And when they treated child-PU A patients with even 16 gray per fraction, they were able to treat without any toxicities. Whereas in child-PU B, they had high level of toxicities, especially grade 3 hepatotoxicity. And then they realized that, they could not go on at the same dose level. And that's why it was found that it was very optimal to reduce the dose down to 5 fractions from 3 fractions, and possibly even reduce the dose per fraction so that the risk of tox. And these patients in child-PU B, when they received these 5 fractions, none of the patients ended up developing any decompensation. So this was a very important factor to keep in consideration. Primarily a lot of modeling studies have been done, particularly from Indiana as well as Princess Margaret, where they've tried to look at chances of liver injury and correlating that with the doses that are received with the liver. And this was the earliest publication where they saw that there is a significant dose volume effect when we try to look for radiation-induced liver disease. And when they correlated mean liver doses, now these cases were cases which were treated with conventional fractionation, and primarily most of them were used for liver metastasis as well as HCC for palliation purposes. And they found that when they kept the mean liver doses to less than 31 gray, there was no RILD seen. And the chances or the 5% risk of RILD was there. If you compare liver metastasis versus hepatobiliary cancer, the tolerance was lesser with HCC when compared to liver metastasis. I think most of the people would know that patients with HCC vis-a-vis the liver metastasis, you would be more conservative in HCCs because the chances of liver tolerance will be lesser. This is another study which actually looked at what should be the volume, especially how much it should be the sparing volume, and whether that predicts the risk of toxicities. And this study by Son et al. Also independently found that the volume at least that we give to 800 cc should be less than 18 gray. And that's what has come out in the recommendations as well, to be treating about 15 to 18 gray. There's a very nice publication where they've looked at various predictors for RILD after SBRT. And if you look here, various factors have been important. So choice of patients, like when you're treating portal vein thrombus, because if it's a long length of the thrombus along the liver, then the significantly larger amount of area of the liver would get radiated. Baseline CP score, mean liver dose, as well as D800 cc also is important, and the mean dose. And they found that in both in child, if you look at the mean liver dose in 6 fractions and the complication probability probably with the mean dose rise. If you see mean dose rise is less rapid in A5 vis-a-vis the A6 patients. And I think this is a very nice correlation. Like if you look at A5 patients and try to see what mean dose you are able to achieve vis-a-vis what are the doses that you are giving to the 800 cc. So you can actually come up with what may be the chances or the risk of developing an RILD. So this nomogram is very effective, and you can see as you keep it less than as you can keep it less than 15 gray, the chances even up to 30 gray to a 800 cc, the risk is very low, whereas when you go higher, you say up to 20 to 21 gray, the risk can be increased. So this is our high risk zone, where as the mean dose goes on increasing, the chances of liver injury is higher. So as per the recommendations, it is good to keep the mean liver doses as low as possible. And particularly for child A and child B, there will be different recommendations. Now, regarding the use of concurrent systemic therapy, this is another study from Princess Margaret, where it was a phase 1 trial, dose escalation study, where they were comparing low and high doses of sorafenib combined with SBRT. And it was seen that SBRT combined with sorafenib had many dose-limiting toxicities. And they predominantly were GI toxicities. So combination of SBRT with sorafenib is usually not recommended. And this is a very nice publication in Advances, where they have compared and come up with some kind of recommendation as to how should we sequence systemic therapy, especially now that we use a lot of immunotherapy. It's not very clear whether we can add immunotherapy along with SBRT or not. We need more studies regarding toxicity of immunotherapy. Whereas at least for bevacizumab and sorafenib, it says that for sorafenib or other TKIs, you stop 5 days before and restart 5 days after RT. But if you're using bevacizumab is known to increase the bleeding risk. You would suspend for at least 4 weeks before and after radiotherapy. So in terms of prevention, that would be probably a more poised approach to take for when you're treating with SBRT. Here, what is very important is to have a proper, careful pre-treatment assessment and selection, child-PU assessment of the functional reserve. You may want to look at pre-treatment assessments and particularly look at existing portal hypertension and how you want to manage them. In terms of radiotherapy planning, it is crucial to look at what volume we are radiating, use more advanced techniques where you're using image guidance and respiratory motion management, and we have to monitor these patients. So optimizing liver function prior to radiation is important. So you have to make sure that medical management of cirrhosis is well taken care of. Hepatitis B and C is often, at least in Indian scenario, diagnosed at the same time that HCC is diagnosed. So then it's important that you refer to the hepatologist. They assess the various viral titers as well as initiate the antiretroviral therapy. Upper GI scopies with treatment for varices, banding, and treatment of medical management of portal hypertension. Now, the liver assessment, function assessment is also something very important. It could be in the form of just blood test to see static tests or dynamic tests, where we carefully look at ICG, where is one of those where we look at clearances, or it could be in the form of elimination like galactose or even metabolite formation. And we often always do these prognostic scorings. And it has been seen that ICG clearance, it gives us a very cool or a very good idea about what may be the chances of liver injury. And it's been correlated even in the SBRT series that especially the indocyanine green retention test at 15 minutes. So it has been seen that indocyanine green, it's very highly extracted in the liver, and how it's excreted from the liver would depend upon how well the liver function is. So most of the time, the excretion or the retention rate is low. It is excreted. So it is less than 10. But if the chances of liver damage are higher, you're going to be seeing that the ICG retention rates are going to be very high. So people have used this for monitoring as well. And if you look at ICG tests done at 1 month or 3 months, a lot of Japanese series also have looked at if ICG is more than 40% or even 50% after radiation, then the chances of liver injury is extremely high. And now a lot of studies are even incorporating the functional imaging, that is with technetium 99 sulfur colloid, that is a SPECT CT, where you can see that the liver, the functional liver could be spared better. And a lot of planning studies are ongoing with this. And mean liver dose is something which is very important. So the meticulous planning to make sure that we achieve these constraints, whether it is 3 or 5 fractions. So if the patient is non-cirrhotic, then the mean dose is quite relaxed for 5-15 fractions because the patient, this particularly like the NASH related ones. But if it is a cirrhotic patient, then especially in child PUB would be really, really conservative, where you make sure that the mean dose is very, very low. And even the dose to 500 cc is what probably you would be looking at. And the dose prescription in HCC commonly is with the help of mean dose, where you would see whether you're able to achieve a particular mean dose, what is recommended for that dose value. If you're able to meet that dose value constraint, that's fine. Otherwise, if you're not able to meet, then you would drop the planned prescription dose to whatever would be the safer limit. And a lot of us, despite treating the peripheries to a lower dose, would boost the central core part. And recently we have started doing a much higher dose in the center for larger HCCs, and we'll probably publish it soon, where we do different kinds of vortices like lattice, and these are actually showing and the periphery is 25, and these show a significant regression. In the last couple of cases, we've seen almost responses up to 50% in them. And this is another publication from Princess Margaret, where they show that in patients who are non-cirrhotic and completely normal, and of course they had majority of patients with liver metastasis, but what they see is that this is particularly true for probably the NASH-associated liver HCCs that we are seeing now. And what they saw that majority had transient toxicity alone, and the 700 cc was one of the main thing that was correlated with even the acute transaminitis. So if as long as you're able to maintain that dose level, the chances of injury technically has come down significantly. And so meticulous planning is important. You have to make sure that there is steep fall off, and you're sparing as much liver as possible. You choose the arcs in such a way that you would spare the doses to the other parts of the liver. Now, what would we do when there's actually your RILD, and the various ways they would manifest or present with pain, ascites, septomegaly, jaundice, or thrombocytopenia. And they could have various syndromes that they could have with decompensated cirrhosis. And encephalopathy is also something which is very commonly seen in these patients. And so I would say RILDs, they can definitely now come to a point where I would say it's a diagnosis of exclusion. We would work up the patient, do the various lab workup. And I think it's very important in these patients to do CT scans or MRI, even correlation with SPECT, to rule out disease progression. A lot of time decompensation is not related to SBRT that we blame to, but is most commonly related to intrahepatic progression. And cytology often in all of these cases would be negative. So it is important to be sure what kind of changes we see. And as you see here, that is the post SBRT, the changes that we see in the liver is a form of a hypodensity. And this is often related to the intermediate dose levels, like between 20 to 30 or even up to 10 gray is what we see. And this is a straight border sign that's commonly seen, that this correlates with the kind of portals that we have used. Of course, this is one where in case of another case in a breast case, probably they went into treating liver, but which resolved completely. So there is no specific guideline for this. It's an integrated approach with the hepatologist. You control the symptoms, you treat portal hypertension. We treat the different factors with the help of medical management. Another toxicity which is important to keep in mind is of a central hepatobiliary toxicity. So it could cause biliary obstruction, liver function decline, and so sometimes even presence of a biliary stent would predispose factors. So here it's important, what dose do we give to the central hepatobiliary tree? And this is the one where they have seen that, with grade 3 hepatobiliary toxicities was seen in about 17.5% of the patients. And so the chances of this happening reduces significantly if we adhere to the constraints and we keep the doses, especially week 26, 30, and the 40 gray that we deliver to these central hepatobiliary tree. So it's important that we we contour them and then see what doses we give. And the management in case there is obstruction is of course in the form of stent. Cholangitis could be treated with antibiotics and of course decompensation. The future directions here that people are looking at is Dr. Deepti did show us about biomarkers, but a lot of biomarkers are now actually also being done to monitor liver injury. We ourselves are working on a phase 1 trial where we're looking at this along with functional liver sparing to look at the levels of interleukin 6 and TGF beta pre-post, as well as there are various imaging dynamic biomarkers these days, especially different forms of dynamic CT and MRI, which may correlate better with liver injury. Of course, prevention is the key. So there are very few treatment pharmacological agents which are available to ameliorate any liver injury. Different form of studies have looked at anti-TGF beta, defibrotide, which may reduce the activation of the Kupffer cells and so the amount of fibrosis. And a lot of antioxidants are also being evaluated to see whether they can modulate the cytokine response and reduce the chances of development of radiation-induced liver injury. So to conclude, grade 3 and higher toxicity post-liver SBRT is now very limited. What would be the key is careful selection of these patients. We should not blame everything on a radiation, especially in this current modern series. So we should rule out disease progression in most of the cases, which is usually the cause. And once rarity develops, the treatment options are quite limited, and hence prevention and meticulous planning is what is the key to getting successful treatment for these patients. Thank you.
Thanks, Shelly. It was an excellent and exhaustive presentation. And you have covered most of the aspects of this toxicity profiling or this liver SBRT. So anyone has any questions to ask? Then I can discuss.
Yeah, Professor Shelley, it's excellent discussion, excellent talk on RALD. It's a difficult topic per se. So I just want to know whether you considered only the child scoring before and after radiation therapy, or you take consideration of L scoring as well, because child has a more of an observer dependent scoring system.
So I would say it's more of we commonly recommend that we also do ALB grades for these patients. So pre and post, because that's more objective, and we know that CP score is what's going to likely change, right? So bilirubin as well as albumin, these are the ones. Most series have shown that albumin also tends to fluctuate a lot, and particularly in our patient, I think the intake as nutritional intake itself is quite poor in the Indian scenario. So this is what I also commonly see, that bilirubin and albumin fluctuates. I commonly use ALB grade case.
Actually, we also look for the LB scoring instead of child scoring. Means going for the LB grade 3 means the patient is going to decompensate. The chances is very high. But yes, for grade 1, it's patient is going to tolerate the treatment as well. So any other symptomatic treatment that you offer to the patient, means the role of glutathione, or either you're using that type of antioxidant during the treatment?
No,
Especially for the larger tumors?
No, I personally have no experience on this. I have not used any. I have read a lot of series showing that glutathione, pentoxifil, and all of these have been tried, but none of them actually have shown much benefit. Like there was one randomized trial from Germany where they've used a combination of drugs, and that showed some possibly reduction in chances of liver decompensation at just short time, but it wasn't sustained. So we don't know what may work and whether the effect is going to be sustained enough as long as they're going to take it. I think Dr. Devnarayan can add on if he's using anything.
Yeah, no, we are not using anything like that because not yet any indications are there for using glutathione and all these things. Acha, Shelly, I have just gone through some of the work where the liver volume is a little different in Indian subcontinent and maybe Caucasian population and American population. So maybe in India it is around 1200 cc to 1500 cc, which you can say 1800 cc in the American population. So the constraint that is used in the lower dosage criteria, which is the American population, do you think that can be used in our population, or we need to integrate and get Indianized or Indian subcontinent?
I think it's a very good idea, because what we have constraints available, or the modeling data which is available, is all from the Western data, and not a lot of that from the at least from Indian or South Asian data. So I think we should definitely look at the tolerability of the liver. We may be surprised that maybe the amount of liver volumes that we may want to spare may be much smaller than 800 cc in our population, actually.
Yeah, sometimes we found the patient with the
Yeah.
remaining liver volume of 700 cc, and then because we don't have any other options, so we hypofractionate those patients.
Yeah.
And somehow the patients are doing well in this group of patients. If we hypofractionate into 10 fractions, so that group of patients also do well.
Yeah. See, since there's some interesting thing that the liver volume actually will depend on the height of the patient and the weight, BSA, body surface area, and the body surface area keeps on changing with different ethnic population. And maybe we able to spare a lesser volume of liver and still get away. And maybe that may be there, but it has to be documented. It has to be in a prosthetic setting to be done.
I'm sure you're doing a similar study on this, right, sir?
We are working on it.
Yeah.
Now, what about? Do you think that the dose what we are giving now, dose of fractions, that has which one is the most important factor? Dose of fractions, total dose, these liver sparing. So there has to be. We should give a priority to those factors, which actually are causing some kind of REL, so non-classic REL. So do you think that which should be the first priority? And in some beginners who is trying to start liver aesthetic.
I think the most important factor would be to spare the rest of the liver, because if you want to safely deliver radiation and develop your own program, it's very important to make sure that you don't have patients ending up with toxicity. So I would always prioritize what is the liver minus GTV, the volume, my selection. I think I would prioritize that. And where probably if you're not able to achieve constraint, you could always either you do adaptive or you really increase the number of fractions that you want to deliver. But I wouldn't do SBRT if I have to just blindly give 50 gray or 40 gray. I wouldn't do that. I would probably, as I said, I mean, to maintain that liver minus GTV dose, I would probably cool off the periphery, but try to give a higher dose at the center of the tumor to achieve a better downstaging. And we know that liver tumors are quite sensitive. You may find dose response relationship in terms of dose for metastasis, but for HCCs, it is still not demonstrated that you have to give a very, very high dose, because
that's true.
A lot of times we give probably only 27.5, but you'll end up seeing quite a
complete response. So that is actually the thing. Means we have to customize the treatment as per the residual remaining liver volume.
That is a very interesting. In lower dosage criteria also, it is up from 27 gray. It is starting to up to 45, 50 gray.
Yes.
So many patients are receive 27 gray and they still have response.
Yeah.
So is there any other question from the panelists? I think we can end the session. So at the end, I'd like to thank Professor Umar, Professor Datta, Professor Shirley for the excellent discussion and talks. And I'll also like to thank other extreme panelists for their important points that they have rose during the discussion. And at the end, I'd like to thank Professor Omata and Professor Sareen and other members of the ALCAP team and for their constant support. So we request you for the constant blessing and support to make the ALCAP to take the ALCAP to the higher level in future as well. ALCAP is usually conducted on every Tuesdays of the month. On every second Tuesday of the month is being conducted. So we'd like to continue in the future as well. So with as there's no other comment, so I'd like to thank you all and close the session for now. Till we meet on the next second Tuesday of the next month.
Thank you.
Thank you.
Thank you for the invite.
Thank you for the nice interactions today. Thank you.
Thank you, Dr. Khan.
Thank you.
Thank you so much. Thank you, Dr. Umar. Thank you, sir.